Okay, so welcome everybody to our lunchtime session on family planning and pregnancy with the Q&A. So just some introductions to those people you can see on the screen. So for those who don't know me, I'm Tess Harris. I'm the CEO of the PKD charity, and I'm joined here by Susan Muirhead, our support manager, who's been liaising with you. Thanks, Susan, for doing all that work and collecting all your questions in advance. We're absolutely delighted to have two guest speakers with us today. We have Dr. Kate Bramham, who's a consultant nephrologist at King's College London, and her colleague Katherine Clark, who's a renal midwife at King's College London, who's actually joining us live from Singapore, where she's based at the moment. But thank you so much for staying up in the evening, Katherine, to join us. Just a reminder, and to let you know that we're supported by the National Lottery, which enables us to hold these events, whether live or in person, and support the work of the charity. We're very grateful to them for their funding. And then finally, a medical disclaimer. So this meeting is for information only. It's not a substitute for professional medical advice or medical examination. And you should always consult your doctor, a pharmacist, or other medical professional if you've got any concerns about your care, or before you take or stop any treatment. And we're not promoting, of course, any treatments or brands. So now I will stop my screen sharing, and I'll invite Katherine, I think, to share the slides and present for us. And about halfway through, there'll be an opportunity for some Q&A because Kate has to leave a little bit early at the end. I'm going to stop my sharing.
Fantastic. This is the time when you kind of want the tech to work really well. Well done, Katherine. Fantastic. Thanks for that introduction, Tess. And I think Katherine and I are delighted to be here. I'm still a little bit in shock at you showing that photo of me pre-COVID and thinking, what's happened? But anyway, we're here, and I was thinking as you were starting about the first event that we had. Again, it was pre-COVID, and we had a fantastic meeting with lots of people attending. But actually, it's fabulous to have this meeting online, because those people who didn't really want to listen about pregnancy don't have it inflicted on them. And I'm assuming that everybody that's here is wanting to learn more. So hopefully we can have a really interactive, engaging session, and we can hopefully provide you with some of the answers that you're hoping for. Next slide, please, Katherine. Now, I think probably most people on this call are aware of this, but I do like to highlight to people that chronic is a word that we use for our kidney disease patients. And I think it's a horrible term. It does mean that it's something that's ongoing, and that's sort of a medical term, rather than it's really bad. So I know several people who've been told they've got chronic kidney disease, even when they've perhaps even got normal kidney function. Their kidneys are filtering perfectly well, and it's just because they've got some cysts that they're known as having this label of chronic kidney disease. So just to kind of reassure you, that's what we're talking about. Chronic means long-term, not going away as such, but it doesn't necessarily mean that it's really bad. Next slide. So I think I'm really excited actually, because things have changed enormously over the last few decades, but certainly even in the kind of 15 years that I've been actively practicing in this space. Historically, a lot of people were told by their doctors who had kidney disease that they shouldn't ever get pregnant. This is a really bad thing to do. And this was a publication that was just before I was born, saying children of women with renal disease used to be born dangerously or not at all if doctors had their way. Many women disobeyed their doctor's orders with a happy result, and few were less fortunate. But I think really wanting to highlight to you that these days are past. A doctor should never tell you that you can't have a pregnancy. If they don't have enough information, they need to refer you on to someone who's able to talk more about that. But really now, in this day and age, we can be very optimistic about all pregnancy outcomes for women with kidney disease. Yes, some are higher risk than others, but I have to say, I think Katherine would agree that of all the women with kidney disease that we look after, polycystic kidney disease is our favourite. The pregnancies tend to go extremely well. But there are some interesting and opportunities around pre-implantation genetic diagnosis, and I'll be talking about that shortly as well. So next slide. But clearly this practice, and I suspect that some of you on this call have experienced this, that doctors have said negative things about a pregnancy to you. And I think probably because a lot of doctors are quite anxious around pregnancy, looking after 2 patients rather than 1. And certainly at medical school, everybody's told it's a bad, complicated thing. But when women have been asked what they've thought about it, they kind of feel very frustrated, I think, and that they feel sad that they've been told not to have a pregnancy. They've felt failure from a kind of cultural perspective or from a family perspective, and that it is really important to have a pregnancy for some individuals. Carry on pressing go. Some of them are actually really angry with us as healthcare professionals, and I totally understand that. And I've looked after several women who've been told that it's not a good idea, and thankfully they haven't taken that advice, and they've come to see me in the pregnancy clinic. But there are lots of changes, as I say, that make things better and safer for women with kidney disease to have pregnancy, and we'll go through a few of those in this talk. Carry on, Katherine. I'm not going to go into detail about how to get pregnant, because I suspect that most people know that the conventional way, but there are obviously other opportunities for assisted reproductive technologies, we call it now, ART, or sort of IVF type approaches that we will talk about. But it can be harder for women if they've got more advanced kidney disease, any sort of kidney disease, not just polycystic kidney disease, because there are changes in the hormonal profile. So women tend to end up, if they've got very advanced kidney disease, their periods stop, they stop ovulating, which is releasing an egg, and the hormones change. They become much flatter rather than these sort of cyclical changes that happen every month. And really kind of the profile looks much more like someone that's perimenopausal or even postmenopausal. So that can make things a bit harder, obviously, to become pregnant. When women have got really advanced kidney disease, such that they might even be on dialysis, we have learned through a fortuitous change in practice in Canada, where they started putting people on nighttime dialysis with lots more hours of dialysis, that actually 1 in 5 women in this group of women in Toronto became pregnant, which is a real surprise to everybody. But it was a good thing, because we learned a lot more about it. Certainly in the UK, well, we're starting a nighttime program now at King's, and I haven't had any pregnancies yet, but I was there the other night, but I don't think anyone was pregnant. But certainly with the shorter dialysis sessions in the UK, it's quite rare to become pregnant on dialysis. As I say, we don't dissuade people from it, and we're pretty good at managing pregnancies on dialysis now as well. Next slide. So for women who haven't managed to become pregnant, and or those who are considering pre-implantation genetic diagnosis, there are obviously assisted conception therapies that we can offer. These can be done privately, or they can be done on the NHS. One of the important assessments that the fertility doctors do, and we can do in the kidney clinic as well, is to send off this test called anti-Müllerian hormone. So this is a substance that's produced by the ovaries. It's produced by what we call the follicles, which is where the eggs are stored in the ovaries. And if you've got lots of eggs, you've got lots of follicles, that means you're producing a lot of anti-Müllerian hormone. If you haven't, if your eggs are starting to run out, you've got a limited number of eggs that you're actually born with, 2 million, but they start to obviously be released, and they fade away as you get older. So if you haven't got as many eggs left, then the anti-Müllerian hormone is low. Next slide, Katherine. And you can see that as you're younger, that the left-hand side of the graph, that the anti-Müllerian hormone levels are higher, and then they reduce. They don't drop off a cliff, as everybody seems to think, as you sort of hit your mid-30s. It's a gradual change, and there are obviously lots of women in their 40s who are able to have pregnancies. Next slide, Katherine. One thing that we have learned from some of the work that we've done, and we're reproducing it again in larger numbers, is that it seems that women, for some reason, who have kidney disease, not just polycystic kidney disease, do have lower levels of anti-Müllerian hormone compared to what we would expect for their age. So on the left-hand side, the control group, the normal people, not normal, but people who have got normal kidney function, that is at 50%. That's where we'd expect it to be across the distribution range. But you can see with more advanced kidney disease, the anti-Müllerian hormone seems to drop a little bit. We don't understand why, but for that reason, I do recommend to women, if they are thinking about a pregnancy, that the fertility might be a bit reduced for their age, and certainly to think about it sooner rather than later if it's on the horizon for you. Next slide. There are lots of issues obviously around assisted conception, and I have to confess the goalposts change all the time in terms of who's eligible, who's not, but certainly obviously it's not cheap for assisted conception, but it is free to have assisted conception for pre-implantation genetic diagnosis if you meet certain criteria, which I'll go on to. Carry on, Katherine. As I said, I always think it's better to just be ahead of the game. So if you're thinking about it at all, definitely it's worth approaching to get a referral. The GPs are only really allowed to refer if somebody's been trying and not successfully conceiving for a year. But I tend to jump that queue and refer women earlier so that they can get everything in place should they need to have assisted conception. One of the challenges historically was that people were very anxious about giving treatments for assisted conception or IVF because they thought it was going to exacerbate kidney disease. But the treatments now, I don't want to speak too out of turn, but certainly as I'm not a fertility doctor, but the treatments now are much more gentle. They are, I hope you can still hear me because I've got a spinning screen. You can, fantastic. And we've done a bit of a look at what's happening in this space for women who've got kidney problems, and it doesn't seem to be substantially greater risk for women with kidney disease. And I am very supportive, as long as that the team know that a woman has got kidney problems. And as yet, touch wood, we haven't run into any serious complications at all. Let me just. Hopefully I can get rid of this. Yeah, well, getting there. Some doctors, I hate to say it, and sometimes male doctors, I'm being very generalized now, are a bit reluctant to refer women. They sort of seem to think that that actually this is sort of taking nature into your own hands, and that you're overcoming these natural fertility barriers that would prevent somebody from becoming pregnant. But my argument is nobody would choose to have kidney disease, and that reproduction is a very important part of not everybody's, but a lot of people's lives, and that if we can assist them to be able to fulfill that, I am very, very supportive. Next slide, please, Katherine. So this is what we really kind of want to talk about in a bit more detail. So pre-implantation genetic diagnosis. So this is the opportunity to screen an embryo, so a future baby, for the polycystic kidney disease gene. And I suspect most of you are very much kind of up to speed on this, but this is the majority of people with polycystic kidney disease, over 90%, have a gene that we can identify, that we know about, which we think we're pretty certain is causing the polycystic problem. So firstly, we need to know which gene it is that you've got, so we would test for that, so that then we're able to test for the same gene in the embryo. Obviously, problems do arise if we don't know, we haven't recognized a gene, and then it obviously is impossible to test for that in the embryo. So that's kind of a bit of a barrier for a handful of people. But what happens is once people have decided to go down that path, that a woman is given some fertility drugs to stimulate the ovaries to produce more eggs. So eggs are salvaged. It's just a simple procedure where some light sedation is given, and the eggs are retrieved through the vagina and sucked out with a syringe, if you like. Quite a simple procedure. And then they're fertilized. So IVF is in vitro fertilization, so the partner's sperm is mixed with the eggs, and they're produced and embryos are produced. So not all of the eggs are successfully fertilized, so we get kind of a bit of a fallout there, even if a woman has got a lot of eggs. So the fertility team watch these eggs very carefully, and once they start to multiply into a few cells, they're able to remove one of the cells and remove the DNA, so the genetic material in the cell. And they test that genetic material to see whether or not the DNA carries that particular gene. Then they know which embryos are affected, they discard those, and then they would select an embryo which is unaffected by the gene and re-implant that into the mother. So there's a 95% chance, even higher probably now, that baby is not affected by the polycystic kidney disease gene. So yeah, it's an opportunity to avoid passing on the gene to offspring. Next slide, Katherine. Thank you. But as I say, we do need to know the genetic mutation. It's only possible to have one child, which is very frustrating by this approach, which seems ludicrous to me, and we've been lobbying to try and change that. Obviously, going through the whole process of IVF is unsettling, can be very stressful for some individuals because you're kind of constantly waiting, you're at the beck and call of the fertility team. There might be a slightly higher risk of complications. We haven't identified it as yet, but obviously kind of interventions can lead to complications. And definitely it's less successful if you have an IVF embryo transfer than conceiving naturally. But just a reminder that only 80% of natural conceptions, so pregnancies that are conceived normally, that they continue. 20% of them, something happens, something goes wrong, that there's either a different type of genetic mutation or it hasn't implanted properly and it results in a miscarriage. So 80%, but it drops down to about 50%. Next slide, Katherine, and we'll go into a bit more detail. So Katherine, if you want to just sort of click through, it should hopefully bring up some numbers. So this is a study that has looked at women who have had, couples I should say, who have had IVF pregnancies with polycystic kidney disease. And a lot of embryos were created for these couples. And you can see that just less than half of these embryos were not affected by the polycystic kidney disease gene. Now, this is just by chance rather than anything else. And theoretically, it should be about 50%. Of these embryos, for different reasons, obviously, some of them weren't transferred, but 24 were transferred. Now, of those 74, I should say, of those 74, the pregnancy rate, so the successful implantation of that embryo, was around 50%. So that's compared to your 80% of other spontaneous conception. And then it drops down to only 20 babies, because obviously something kind of happens in that early stage of the pregnancy that may be less successful. So only 37% of these embryo transfers end up being a successful delivery. But that compared with IVF treatment, depending on which clinic you go to and who's quoting what results, can be as low as 10%. So certainly individuals that undergo IVF treatment for this purpose tend to have much better outcomes, but obviously it is lower because it's an intervention and the body might behave differently. Next slide, Katherine. Thank you. But you're entitled to 3 cycles on the NHS, and this is another study that's looked at the success of the cycles. So gradually, after you've had 3 or more cycles, you're looking at getting up to nearly sort of 60% in terms of having a successful pregnancy as a result of the pre-implantation genetic diagnosis. I've looked after women who've sadly, just to be perfectly honest, have gone through these cycles and then they've decided just to conceive anyway because they were unable to afford it, and as luck would have it, all was fine. So who knows what the right choice is, but definitely we're very supportive of women being referred and going down that pathway. Again, people have got different opinions about whether or not pre-implantation genetic diagnosis is an appropriate thing to do. I am very supportive. I think certainly as a mother myself, I'd be keen to avoid passing on a condition if I was struggling with it to my offspring. But that said, a lot of women decide not to. They feel that their disease hasn't affected them a huge amount, and that they're happy to go ahead anyway. So the other thing I often say to women is that treatments are changing a lot for polycystic kidney disease as well. And so if their offspring, if their baby child, it has got polycystic kidney disease, has inherited it, then there potentially would be lots of different treatments available when they're older and potentially more affected by the condition. Next slide, Katherine. Brilliant. And interestingly, a number of people with polycystic kidney disease were surveyed, and only 50% of them before they started dialysis said that they would go down this path. But more of them, 63%, once they started dialysis, felt that that would be something they'd want to avoid passing on. Click again, Katherine. And interestingly, geneticists are much more familiar, I guess, with this territory and much more likely to be supportive. Pediatricians again, but adult nephrologists a little bit slow to change. So do keep banging on your consultant's door and say that you've been to this talk and that it is an option for you. So there are unfortunately sort of regulatory criteria that people need to meet, and there are national guidelines for this, and just as I flick through them quickly. So it can be the man or the woman who's affected by polycystic kidney disease who are entitled to PGD. The condition must be considered to be serious, which polycystic kidney disease is, thankfully. They need to be referred, which can be done by your consultant nephrologist to an NHS clinical genetics service, and there are different hubs now around the country. The risk of conceiving a pregnancy affected must be 10% or more. Well, it's 50% because it's 50-50 whether or not you get the gene or not. And the couple must have had genetic counselling, and that's provided by the clinical genetics service. Next slide, Katherine. So the female partner must be under 40 years of age. Now, I don't know whether or not that's going to change at all. It does seem a bit strict to me. Needs to be not too heavy. Again, that can sometimes be a motivator for some people to lose a bit of weight before going through it, because we know that the pregnancies are more complicated in people that are heavier and very light, obviously. Non-smoking. And this is one thing that's a bit tricky, that neither of the couple must have a living child that's unaffected. So if individuals have already, if a couple has already had a child, then they're not eligible. The child's not affected, they're not eligible for PGD. And it can't be if the problems with conceiving in the first place that you're sort of seeking that pathway. Next slide. So I said the 3 cycles, unless it looks like it's going horribly wrong and there aren't enough eggs. So NHS staff might suggest that it's not appropriate to do a 3rd. That there are all sorts of criteria about if you've got embryos stored, whether you can or can't use them, etc., etc. But that's something that can be discussed in detail with the fertility experts. But if you've got stored frozen embryos, then the preference is to use those first. And there's a link there to the current guidelines. Next slide, Katherine. What if you've got a kidney transplant? Can you still pass on the condition to your child? Well, yes, unfortunately, because the genes are coming from your ovaries rather than anything to do with the new kidney, and the eggs were formed before birth. So yes, that is possible, both obviously for men and women actually. But we do have good outcomes from people who've had pre-implantation genetic diagnosis with kidney transplants. And women with kidney transplants tend to have good pregnancy outcomes as well. But we do recommend that you wait for a year after having a kidney transplant to make sure that it's not going to reject and that you're on the right medications that aren't going to affect the pregnancy. Next slide. And obviously, if the male partner has got polycystic kidney disease, again, the risk is 50%, but PGD is possible. There are some reports of polycystic kidney disease affecting male fertility. It's not widely investigated, to have to confess, and that certainly the patients that I have looked after haven't reported that to be a problem. But obviously, it might be something to bear in mind and to refer early if there are problems. Next slide. That's Katherine. I'm a twin, so I'm allowed to say this, but definitely we don't recommend, if you've got kidney problems, having 2 or more embryos transferred, because it can put much more strain on the poor old kidneys in the pregnancy. Next slide. So planning a pregnancy, there are things that we need to think about medication, and I'm just going to focus on 2 areas to start with. Next slide, Katherine. There is obviously a bit of a tussle between who tells you what, and everybody tells you different things, which can be difficult. Obstetricians are usually right. They know their game much better than the nephrologist, and certainly there are pharmacists who like to give advice as well. But what I recommend is that you carry on taking your medication until you have a positive pregnancy test. And as soon as you have a positive pregnancy test, then you need to seek advice and then get changed onto pregnancy-friendly medication. Next slide, Katherine. So these are the ones that everybody panics about. These are the ACE inhibitors and the ARBs, as we call them. So anything that ends in pril or sartan, everybody says, oh, no, stop. Because historically there was some suggestion that they caused harm to the baby. But we now know that it's more likely to be the condition that leads to the mother needing to take those medication that causes the harm. And we think, and there is some evidence to suggest that if you stop it too soon and you enter pregnancy with blood pressure that's not controlled, or your kidneys are leaking a lot of protein, that actually the pregnancy outcome could be worse. So what I tend to do is recommend that women take regular pregnancy tests when they're taking these medications, but that means that they can go into the pregnancy in the healthiest possible state and stop straight away. Tolvaptan Jynarque, that there is a signal that it does do harm again to the baby, but it comes out of the system pretty quickly. So I suggest that women either stop taking it when they're planning to conceive, or as soon as they have a positive pregnancy test again. Next slide, Katherine. Brilliant. You can buy these on the internet, really, really cheap. You don't need to faff around with the plastic bits, just get them in a pot, just like we do in the hospital. Brilliant. Carry on, Katherine. Keep going. Next slide. Fabulous. I do warn women that it can be a bit more complicated, and we do like to keep a very close eye if you've got kidney disease. So it becomes a little bit more of an industrial process. But I have to say, most women that we look after really like that. They like to have that regular contact with the doctors. They like to have that reassurance, and you definitely get a lot more scans if you've got kidney problems and you're pregnant. Next slide. One of the things to just be warned about, but to be aware of, is that we do testing at the beginning of pregnancy, around about 12 weeks, to check for chromosomal abnormalities, and the best known one is Down syndrome. Now, if you've got reduced kidney function, that might become falsely positive, and that's because the kidneys get rid of one of the substances that we use to predict this risk of having Down syndrome. So it increases, you see the graph on the right, increases as the kidney function gets worse, the creatinine goes up. So what I recommend if women have a positive screen for Down syndrome is that they go on to have this free fetal DNA. This is the Harmony blood test, which actually looks for the baby's DNA in the mother's blood, and we can confirm that very quickly and reliably, rather than having to do invasive tests. And what I often do is that women with more severe disease, I suggest that they don't, when they do the calculation, that they remove that factor, the beta HCG, in the equation, and the obstetricians can do that. Next slide, Katherine. So we keep a really close eye on you, keep a really close eye on the growing baby. Next slide. Things that we look for in the mother is that we keep a very close eye on blood pressure. We like to control that well. We know that women have fewer complications if we keep it lower, but making sure it's not so low that the blood flow to the placenta is compromised. We'd expect the blood pressure to get better in pregnancy, and it usually falls, and women can usually have a little bit of time when they're taking fewer medications for blood pressure, but it does tend to rise towards the end. That doesn't always mean that there's something going wrong, but women with polycystic kidney disease are a little bit more inclined to get blood pressure, even if they haven't had blood pressure before, towards the end of pregnancy. Next slide, Katherine. We also see that the kidneys get better in pregnancy. Unless you've got quite advanced kidney disease, we usually see a lovely fall in the creatinine during pregnancy, and that is a really positive sign. I love seeing that. It's one of the few cures for kidney disease pregnancy. One thing we can see in pregnancy is that the kidneys get bigger. And that's not permanent, that's just temporary. There's lots of blood flowing to the kidneys. And we also see that the tubes that connect the kidney to the bladder tend to get a little bit more swollen, a little bit more dilated because of hormones, and because the baby gets a bit in the way and causes a little bit of pressure there, and it tends to swell up a bit. That's completely normal. If we were to scan everybody, 80% of women would have these changes towards the end of their pregnancy. We do tend to see more protein in the urine in pregnancy, and that can sometimes get really high, cause really frothy urine, and particularly if you've got protein in the urine already and we've stopped the medication, those sartans or sinoprils, and we have to watch it very closely. But we're looking closely for it to look for a condition called preeclampsia as well. Preeclampsia is a condition where the placenta isn't working so well, and that can cause problems for the baby's growth, but also can release toxins into the mother, which do affect the kidney, cause the blood pressure to go up, and also cause protein to leak. Very occasionally, if there's lots of protein in the urine, just click ahead, Katherine, we sometimes need to introduce injections just to keep the blood a little bit thinner, because the blood gets stickier if it's losing some of the proteins in the urine that stop the blood from clotting. Next slide. And as I said, preeclampsia, this is the condition where the placenta fails to form properly. And we don't know why women with kidney disease are more likely to be affected. But certainly with polycystic kidney disease, it's definitely worse as the kidney disease becomes more advanced, but it's not as bad as some kidney conditions as the risk of preeclampsia, probably about double in this series, but only 10% rather than 5%. And that's our job as kidney specialists, as obstetricians, to keep a close eye, spot the preeclampsia when it arrives so that the baby can be delivered at the right time, so that it's as healthy as possible and that the mother doesn't run the risk of having the toxins released into her system for too long. Liver growth. Now that's a tricky one. Definitely there are some women who the hormones of pregnancy cause the liver to grow, the cysts to grow, and that sometimes is not reversible. It's impossible to predict who that's going to happen to. And certainly when you look at a big number of women, the majority don't have any problems with their liver at all. But I do have a few women who have definitely recognized that their liver has grown during the pregnancy. And as I say, I don't know who it's going to be. And obviously it's something that we're kind of aware of, and we're hopefully going to be able to answer some more questions about in the future with some of the research we're doing. Next slide, Katherine. We do know for some women that their kidney function can get worse in pregnancy. And again, that's those women with more advanced disease. So looking kind of over to the right of the slide here, this is the creatinine, which is the marker in the blood that we use to measure how well the kidneys are cleaning the blood, and high is not so good. But if we look at the changes before pregnancy and how rapidly it's rising, pregnancy doesn't tend to accelerate that much unless you've got what we call stage 3B kidney disease, which is when the kidney function is less than 45%. And we say that if you're moving into that stage, that you might kind of push your kidneys a bit faster towards ending up needing to have dialysis by about 2 or 3 years by having a pregnancy. But that's only if you've got more advanced disease. If you haven't, there's no risk. Carry on, Katherine, brilliant. And then watching the baby. Now, I am no expert, and the obstetricians are always trying to persuade me to have a go at scanning, but you really wouldn't want me scanning your babies. I'm far better at dipping urine, I can tell you. But the obstetricians are amazing now. They're really good at spotting when babies are looking sick. They can look at their blood flow, they can look at the blood flow to their brain. And so they know, they can tell when's a good time to deliver the baby. But we do know if you've got more advanced kidney disease, the graphs here with the paler bars with women with more kidney disease, with more advanced kidney disease, we do know that women are more likely to have smaller babies, early babies, and the babies might need some special support. But overall, the risk of having a live baby, or the risk of having a baby that doesn't survive is equivalent of a woman without kidney disease now, because they're so good at looking after babies inside and out. The neonatal services are brilliant. Next slide. So we do all these fancy tests, and maybe Katherine can go into more detail about that, but we can track how well the babies are growing, and we can see if the placenta is not working so well, if the baby's starting to struggle, and we can usually give a fairly clear steer on whether you're going to need delivering early. Around about sort of 32, 34 weeks, we can see if things are starting to go amiss. Next slide. Brilliant. But as I say, we do love looking after women who've got polycystic kidney disease. The babies tend to do extremely well. And certainly in this series of 54 women who with polycystic kidney disease, there was no difference in the baby's outcomes as women who didn't have polycystic kidney disease, just had the odd simple cyst in their kidneys. So it's all very positive, I think. Brilliant. Fantastic. So I'm going to hand over to Katherine now, but I wonder if we just pause for a little bit and just have a few questions if anybody's got any. And just to remind people to put them in the chat if they don't want to put the camera on or don't want to be recorded. There's no pressure, and we do want people to preserve their anonymity if they want to.
Thank you very much, Kate. We do have one in the chat, but there may be perhaps from the earlier questions that were sent in advance. Is there anything that was relevant to your particular topics.
There's one in the chat saying, could IVF increase the size of the liver? That's a really good question. I guess theoretically, because there's increase in estrogen hormone, but it's for such a short period of time, not like the 9 months of pregnancy that the liver is exposed. I've never seen it. I would tend to say not, but I don't honestly know.
I had a question about the routes, if that's all right. The routes to the pre-implantation. In my situation, I have normal kidney function, but it's my partner that has polycystic kidneys. So we're unsure about, is it him that needs to get?
Yeah. So he would be referred and you would go along.
Do. Okay, yeah. And then we would be referred to the geneticist, is that right?
Correct. Yes.
Okay.
Absolutely.
And then would we both need to be there for all of the appointments, or then does it become more of like my kind of?
Both of you tend to attend the most of the appointments, certainly all the counselling appointments and the discussions around it, and then obviously kind of some of the kind of follow-up appointments would just be you potentially kind of going to have the eggs and things stored and things like that. Yeah.
Okay. Thank you.
No problem. A couple more questions in the chat. Just wondering if there's an age where you'd recommend having children before. It kind of depends on what your kidney function is like. But as I said, because of this uncertainty about fertility, I do tend to recommend that women have them sooner rather than later, particularly as blood pressure gets higher as you get older anyway, and if you've got polycystic kidney disease. But if you've got very good kidney function, I don't think there's any rush, and certainly I can't think of anyone that I've looked after recently who's younger than 30. So it's very normal for me to look after women in their late 30s with polycystic kidney disease. Yeah. Does the ovarian reserve only decrease if kidney disease is advanced? Well, that was one of the surprising findings from that piece of work that we did, that actually even with relatively preserved kidney function, that it does seem to drop a little bit. And we don't know why, but it seems to be a pattern across different chronic, there I go again with that term, but long-term illnesses, and probably due to inflammation that might be affecting how the kidneys are working. So again, this test is very easy to do, the anti-Müllerian hormone. So it's all sites should have it now to be able to just do that with your routine blood test. So it's definitely worth doing that to find out where you're at in that path. I'm a PKD patient, not married yet. My question is, will I pass this condition to offspring? My age is 25 and have blood pressure also. So there's a 50% chance that you could pass it on to your offspring, because you've got one affected gene and one unaffected gene, and it's the affected gene obviously that causes the problem. But you only pass on one gene to your children. So possibly 50%, but if you want to avoid that, then you would need to go down be referred to the genetic services for pre-implantation genetic diagnosis. Sarah, I would say discuss it now. Definitely discuss it now, because the referral pathway takes time. It takes up to a year sometimes, I'm afraid, sort of 6 months maybe to get a diagnosis. Sorry, okay. I was told I could use this room, but I'm just giving a presentation. I'll be out as soon as I can. Yeah. Okay.
We have a hand up from another Sarah. Is that the same Sarah?
Yes. That's me. Can you hear me okay?
Yeah.
So I've got PKD, but my kidney function is normal. I've had a baby through the PGD route. But my main concern, so we've got 2 frozen embryos. We're very, very fortunate position. But really it's the liver cysts, which I just can't get any sort of clear guidance on. So I know that my cysts are large in the liver. They didn't seem to affect my pregnancy, but I'm just conscious that I'm either, increasing their rate of growth through getting pregnant potentially.
I know that women who have had, it tends to be a pattern. If your pregnancy affected it the first time, it tends to the second time. If it doesn't the first time, it doesn't tend to the second time.
Okay, so I think, the piece of information I probably need to obtain is probably looking at my scans from before the pregnancy and after, and getting someone to analyse those to give me a bit more comfort, maybe.
Yeah, good plan.
And
can
Sarah,
you self-fund?
Oh, sorry, Sarah, we do have a lunchtime seminar next Thursday on polycystic liver disease.
Okay.
So if you can attend that, you'll see the event listed on our website.
Okay.
Otherwise, we can ask that question for you if you'd like to drop us an email.
Yeah,
and
that
then
would
get
be
back to you with
brilliant.
an answer from Dr. Ahmed Al-Kashawi, who's an expert in PLD.
Okay, that would be fantastic. Thank you.
Just a quick answer to Ben in the chat there. Can you self-fund a second round of? Yes, you can. Yes, indeed. I'm going to drop off because I'm being booted out of my room, I'm afraid, but I will move and I'll keep an eye in the chat. Hold on.
Not a bother. While you're moving over and Catherine's taking over there, well, just a quick question that came over anonymously. Someone was just a little bit late in arriving, and is there anything they should be doing pre-conception? Now, I know Kate did mention pre-conception, and we'll certainly get the recording out because I know so far there's been no breach of privacy throughout the presentation there. So we'll certainly have that recording, and I will email it to everyone who's attended today. So as soon as it's available, now it might be into next week. I'm not promising a time scale, but we will have it to you because we have another face-to-face human interaction at the weekend. We actually have our first patient information day happening on Saturday post-COVID. So the team are kind of committed to that, but we'll certainly, as soon as it's published, we'll let you know.
So I've just stopped Kate's video while she settles herself in another room. There is a question here from Sarah in the chat. Perhaps Katherine, you might be able to answer that one.
I think about the timing of getting in touch with people if you're thinking about a family in the next year or two. To Kate's point, I think the sooner the better. There's a lot of sort of ducks to get in a row ahead of planning a pregnancy, particularly if you're thinking about pre-conception counselling. So I think, yeah, sooner rather than later. So if you're thinking in the next year or two, then certainly now would be a good time to start those conversations. And the same for the pre-conception conversation, although we're giving sort of the general advice, which is what Kate started with. A lot of the advice around medications and things like that is worth seeking from someone who knows your case really well. So if you are planning a pregnancy and wondering what you can do to optimize your pregnancy journey, then having a conversation with your doctor sooner rather than later, even if you're thinking about 5 years from now, is sensible, so that you can get a steer on what's best to optimize your chances of the least tumultuous journey possible.
So Katherine, would you like to put the slides back up and share them again? I think you had a few more.
For sure.
Go through in there.
Perfect. So do keep those questions coming because we can come back to them at the end. But what I will do is just carry on the journey. So we've got to the point where you've had your pregnancy. That pregnancy has been managed well by a big group of people. So your nephrologist, your obstetrician, you'll have had midwifery care throughout the pregnancy as well. And you get to the point where you're thinking about how to birth your baby. The first thing to say is that the plan for the vast majority of people is wait till you go into labour spontaneously, and hopefully that's around the time that you expect your baby to be born, so around that due date, acknowledging that we don't actually know when babies are going to come. We give a window between 37 weeks and 42 weeks of pregnancy, and birth in that window is considered term and perfectly healthy. But it is a balance, and we're often having to think about when's best for you to give birth, to protect your kidney function, your liver function, your overall health, but to optimize the condition of baby. So for the vast majority of people, actually we're considering timing of birth based on mum rather than baby. But for some people, it's also based on what's going on with baby, as Kate talked about. So we're monitoring you both closely. When we think about mum, there are some things that will tell us that we shouldn't keep waiting. So we want to plan labour, plan birth before we get to your due date or around that due window. So some examples would be if we can't control your blood pressure despite medication, if we're seeing that your blood tests are changing to suggest that your kidney, liver, and some of those other sort of things that need to keep stable to support a pregnancy and for you to stay healthy are changing dramatically, then that might be an indication. Of course, we keep an eye on baby to make sure that we're making a sensible plan for you both. And we'll be asking you about symptoms, and really that's symptoms of preeclampsia, that condition that Kate thought about. Because particularly in someone with blood pressure and proteinuria before becoming pregnant, it can be quite tricky to diagnose preeclampsia because there are two primary diagnostic factors. We are getting a bit cleverer, and we have some blood tests that we can use that are quite sensitive to the diagnosis of preeclampsia. Unfortunately, they don't work quite so well in kidney disease, but they're still very useful. So we are getting better at it, but that's what your team will be thinking. Is this preeclampsia, or is this just your normal kidney function changing a little bit towards the end of pregnancy? It really is a balancing act. How are you likely to give birth? Well, actually, for most people, even when they do have kidney disease, they're likely to have a vaginal birth. So they're likely to give birth in that sort of more natural way. But there is a higher chance that we're going to have to bring on that birth a bit sooner than you're going into labour spontaneously. It's unlikely that your pregnancy will go much past your due date. So you can see here for someone with chronic kidney disease, this is all chronic kidney disease, not just PKD. Without preeclampsia, about 40% will have an induction. That's where we use medicine to bring the labour on. And an even higher percentage will have, so almost 60% if you have preeclampsia on top of the kidney disease. That's compared to about 5% in people who don't have kidney disease. The chance of us getting to the point where we want to plan a cesarean section. So normally that's because we're worried about baby. So we don't think baby will tolerate a vaginal birth. Again, those rates are higher in someone with chronic kidney disease than in the normal healthy, in people who have normal kidney function. So why are we trying to push for a vaginal birth? Why don't we just say, actually, if you need your baby to be born before you've gone into labour spontaneously, why don't we just do a cesarean section? Well, it's because vaginal birth is healthier. There's a reduced risk of lots of those of certain complications in this pregnancy, but also there's a reduced risk of problems in future pregnancies. And you'll be in hospital for less time, so you get to go home sooner, but also that has positive impacts on your health, less likely to have infections and blood clots. And there are risks associated with cesarean sections. About 16% of the time there's some complication with a cesarean section. It's a very practiced and very safe operation compared to lots, and most of those complications are very easy to manage, but we just have to be honest that they are possible. So we want to promote vaginal birth if that's the safest option for you. If we are having to bring that vaginal birth on before you've gone into labour spontaneously, there's a few things we can do. That people on this call might be a bit too young to recognise that little puppet as sweep, but we can offer you a membrane sweep, which is a vaginal examination trying to encourage natural labour to start. But then we can use medications and procedures as well. So we can use a medication that we put into the vagina. We can also break your waters, that's the rupture of membranes. And then we can use a drip, so a hormone drip, to encourage those contractions to come on. It's quite a lengthy process, induction of labour, and we do need to keep a close eye on baby because babies sometimes find it a bit more stressful than spontaneous labour, but it's a very safe procedure. For people who have kidney disease, often a consideration is, if I do have a natural birth, what pain relief is available to me? And all the natural pain relief mechanisms that work very well, so mobilization, water, and something called a TENS machine, all natural with no risks, but significantly reduced pain scores, work well and are safe for you to choose. And also all the medical pain relief options are normally safe for you to use. So gas and air, and epidural. And also sometimes we offer opiate medications. We do need to be a bit cautious depending on your kidney function and your other medications around using opiates, but the others are very consistently safe. We would ask you to see an anaesthetist during your pregnancy if you were heavier, or if we had some worries about your clotting ability, the ability of your blood to clot. So if your platelets were lower, if you were on those injections Kate mentioned earlier, or if you're on heparin, then we would ask you to see an anaesthetist just to make an individualized plan to make sure what I've just said is still true for you. There are some times where actually an induction of labour, so bringing on labour or considering a vaginal birth, isn't so safe. And that's when we're worried about the placenta. So the placenta not working so well. And of course, a caesarean section does have benefits. So there's reduced pain, we can plan it. There's obviously not that vaginal trauma of a vaginal birth. And you are less likely to have a substantial bleed within the first few days of birth, because the caesarean section can be a more controlled environment. We also need to think about your individualized risk of needing an unplanned caesarean section in labour, because we know that the risk of that from an induction is about 25%. So if your risk of having a caesarean section in labour is very high, then we would plan just to have that caesarean section if you were happy with that plan, rather than do it in the uncontrolled setting that can happen during labour. So how does this compare? How does the bigger picture look? Well, the national caesarean section rate, these data are a little old now, I need to update them, was about a quarter, just over a quarter. And you can see actually for someone, the bottom right box there, someone with chronic kidney disease with preeclampsia, remembering this is all CKD, the chances of a caesarean section is about 90%. So it is a lot higher. But remember what Kate said, actually PKD is one of our sort of more straightforward pregnancies to manage in terms of kidney disease. And so actually for you guys, this percentage is probably lower than that. You've met your baby, what to expect? Well, again, it probably depends on your journey. If you have had preeclampsia, and chronic kidney disease, then you are more likely to have a baby that needs some extra support. And that's normally because the baby's come before its due date. So it's just a bit premature and needs some support. So it's normally for a shortish time, and it's relatively low levels of support, but it is about 40% if you have CKD and preeclampsia, but about 9% for most people with chronic kidney disease. We do want to keep an eye on you in those first few days after the baby's been born to check your blood pressure's okay, to make sure we've got your medications right, and to help you establish breastfeeding. So it's likely that we'd ask you to stay in a little bit longer than most, so maybe a couple of days after the birth. But this is a conversation that you would have with your team. And then we need to keep an eye on you after you've gone home too. So those nice sofa cuddles that you can have with your baby, we need to remember to keep an eye on you as well as your little new one. One thing that's really important to be aware of is that we want to keep things as straightforward for your kidneys as possible. So we don't want to give them any other big hits. So we do use non-steroidal anti-inflammatory drugs, so things like ibuprofen, diclofenac on the labour ward. And so something that will be important for you to plan with your team is to avoid those medications, just to make it as straightforward for your kidneys as possible. And then the opiates, as I've mentioned, we just need to be cautious about. After the baby's born, it's really important that we review your medication to make sure that you're on everything that you can be on, because often we get a bit scared, particularly if it's people that aren't so familiar with kidney disease, and stop things considering breastfeeding. But that's very seldom sensible. It's often the case that we can add meds back in once you're not pregnant anymore, rather than stop anymore. We also want to make sure that you're drinking enough, but not too much during labour. So we will ask you to do things like measure your wee to make sure that you're weeing out as much as we're putting in. And we want to make sure that you're nice and hydrated. In terms of breastfeeding, just ever so briefly, it is something that's recommended worldwide by the World Health Organization, and it is of benefit to babies. It's important, particularly when you've got kidney disease, to make sure you're drinking enough water. Anyone who's breastfed will tell you how thirsty you get, and it's hard to keep up. So it's important that you remember to keep hydrated to avoid any further hits for your kidneys. We would recommend considering some hand expression of breast milk whilst you're pregnant. That can really help you out, particularly if you do end up having a baby who's in the neonatal unit for a little while. And that's something you can expect your midwife to support you with during your pregnancy. As I've hit on, most drugs are perfectly safe when you're breastfeeding. This chart shows that they've got a long way to go before they get into the baby's blood. So actually a lot of the drugs are metabolized way before they reach the baby's blood. And so the chances of a medicine having an impact on a baby that's breastfeeding is really quite low. So it's important that we have those individualized conversations around which medicines are safe. And actually, most of those medicines that Kate spoke about at the beginning are perfectly safe to take when you're breastfeeding. But again, it's about those individualized conversations to make sure that your blood pressure is optimized. Those conversations need to happen, perhaps not with this GP just there, but with your GP, your health visitor, and your community midwife. We need to have that joined up care to make sure we're not forgetting about you, because often the focus really is on the baby. So joined up care is really important. We need to make sure that you get back in with your kidney team so that you're not going to fall out of that system, and that we're managing to keep an eye on your blood pressure, your urine, your medicine, and thinking about contraception, particularly if this was an easily conceived baby, because we want to give your kidneys a bit of a break post-pregnancy to make sure everything is good. And the key is to make sure we're all talking to each other. So feel free, particularly to engage your partner in making sure they're your advocate whilst you're juggling breastfeeding and all those other things that you expect in the postpartum period, to make sure everyone is talking to each other. One thing to be aware of is that sometimes people will try and dip your urine in the postpartum period, particularly if they know you have kidney disease, but you're bleeding and blood is protein. So it's not a useful test. So if anyone tries, please say, not right now, wait till my bleeding has stopped. We can't learn anything from that dipstick in the postpartum period whilst you're still bleeding. It's important, as I've hinted, that we just keep an eye on what's happening with your kidneys in that postpartum journey. Postpartum being from the birth of the baby to a year after the birth of the baby. For most people, their kidney function will stay stable even when they do have kidney disease. But for some, their first reduction in kidney function will happen after the birth. So you can see there, 23% will see that reduction between delivery and 6 weeks postpartum. And then you can see at the top there, a further 10% will see it in further past the birth than that. So we just need to keep an eye on you. And that's why it's important to get you back in with your usual care providers. So what to expect from your midwives and doctors through your pregnancy? Well, it's to be treated as individuals, to be treated like royalty. Make sure you're getting individualized care. You're part of the decisions. Your care is coordinated, and your midwife should actually be the golden thread that makes sure that everything is happening. All the right people are involved in your pregnancy, and everyone is talking to each other. So I think some of these conclusions are clear, hopefully. Pregnancy is possible for most people with CKD and very safe. Fertility treatments might make pregnancy more likely, particularly if you have more severe disease. And it's important that we keep an eye on you closely to make sure that you and your baby are as safe as possible. But we should certainly expect a really positive outcome. I will stop sharing and we can come back to these questions.
Thank you very much, Katherine. I know Kate is still on the chat. I'm not sure whether she wants to join again by video, but or whether it's inconvenient. We've still got, it is just past 1:30. That passed very quickly. Are you happy to hang on just a few more minutes in case there are any additional questions?
I am, of course. Yeah, sorry that went on a little bit.
No, we had so many questions in the first half, which was great.
Absolutely, and we thought that might happen, so to make sure that Kate was around. I'm just trying to
Susan, was there anything from the advanced questions that might be relevant?
The majority of the advanced questions were answered during the slides. A lot of it related to implantation, genetic testing. But I do see there's one little question popped into the chat there, and I think it was Kate did mention the standard tests usually done 12 weeks into pregnancy, and mentioned sometimes that creatinine levels can knock some of them off. I think the question relates to that. about genetic testing at 12 weeks in pregnancy. Is that offered in all areas to all parents?
Yeah, so genetic testing is not routinely offered in pregnancy. And I think the ethics around genetic testing once you're already pregnant are considered to be a bit more challenging. So obviously that's a very personal interpretation of what is ethically right, but I think that's the challenge that service providers have had. So it certainly isn't universally offered. Genetic testing is much more available pre-conception. It's something to talk to your local services about, and certainly if you were looking for advice on how to go about that once you were pregnant, and there are referral centres that you can seek genetic input from, King's being one of them, once you are pregnant.
And Lottie's asking in the conversation, did I see a comment that we can have aspirin?
Yeah, absolutely. So you're right there, Lottie, and it's the reason that we sort of skimmed over that a little bit is that there might be some slight confusion in the data that's out at the moment. So we used to be very quick to promote aspirin for everybody, and it certainly is very safe, and it reduces the risk of preeclampsia in people who have extra risk factors. So the advice now is certainly still to take aspirin, low dose aspirin, so it'd be 150 milligrams from 12 weeks pregnant, perhaps before, throughout the pregnancy until about 36 weeks, and we think that reduces the risk of preeclampsia. So that's very likely to be the advice, and likely to remain the advice, but yeah, just a slight question mark over the dose at the moment. So that's why that's there was a slight look over there. I noticed Amy said she's allergic to aspirin. Is there an alternative? Sadly not, Amy. It's such a low dose and such a gentle medicine that we don't have an alternative. There is some evidence that taking other anticoagulants can help if you're at a very, very high risk of preeclampsia, but that would only be someone with quite advanced disease. So the risks would outweigh the benefits of taking anything other than aspirin unless you had more severe disease.
Yeah, and I see Georgina's popped a lovely comment there in the chat, which is just a nice place, I think, to finish off for the day. And it's just a thank you all for such an informative and helpful chat. I feel well informed and have an increased knowledge now for if I am ever lucky enough to have a child in the future. And I think that's a lovely comment just to finish off on.
Absolutely, most definitely. Thank you so much, Georgina.
And we've had some more appreciative comments come in as well. So I'd like to thank you both. Thank you very much, Kate, who I think is still listening in on this. And thank you, Katherine, for taking time out of your lives and your evening in particular, Katherine, to spend time with us. And just I'd like to thank everybody who attended the meeting. If you do have any questions that occur to you afterwards, please do send them to us and to Susan or info@pkdcharity.org.uk, and we can pass them on to Kate or Katherine, and I'm sure they'll be happy to answer them for you. As I said, this will be uploaded to our website, and we will also be contacting you afterwards with a short survey to ask for your feedback on this meeting. Thank you very much indeed. I'll now end the recording.
Yeah, thank you everyone. It's been a good hour.